chances, I think this one does have a laser. Hey, Tim, does it? Okay. All right, good enough.
Joe Rosado. Good to meet you. See you again.
Thank you for being able to fill in with a little extra information.
All right, Tim, we're recording? Okay. Good afternoon, everybody. My name is Gene Jones. I'm the executive director for CanEd. It's a small nonprofit organization that assists in educational and networking activities related to the cannabis industry, specifically medical cannabis. If you will allow me, I'm going to go ahead and get us started so that we can get the program going. I'm going to hold off on my opening comments until tomorrow morning. If I could, I'm going to go ahead and introduce Dr. Barton Hirschfield, who's with the Medical Cannabis Physicians of Southwest Florida, and Doc is going to moderate this session. We do have one potential speaker that may not be able to join us, so I think Dr. Rosado and Stu will probably be able to take care of some extra time, so thank to both of them. So Dr. Hirschfield, it's all yours, sir.
Thank you. Well, good afternoon, everyone, and welcome to the 2025 edition of the Florida Medical Cannabis Conference and Expo. I'm Bart Hirschfield, a qualified physician in Florida's medical cannabis program, and also an active member in the Florida Medical Cannabis Physicians Group, which is a volunteer physician professional association whose members share the core value of providing sound cannabinoid education to our patients, and whose mission includes advocating for medical cannabis patients and physicians. We meet monthly during Zoom if you haven't signed up for any of the meetings, and also once a year in person right here. And in fact, the meeting will probably be after the welcome reception in the exhibit hall around 6:30. So please, you're welcome. If you've never joined us before, please feel free to come on and sit in. And if you have participated with us before, then we'll see you then. All right. As Gene mentioned, originally we had 3 speakers scheduled. We're not sure if the first one's going to make it. If he does before, we'll definitely get him queued up to hear his presentation about cannabis policy. But we do have speakers with 2 interesting topics. One being a case report of the outcome of a complicated individual patient, and the other, a statistical analysis of outcomes of a large group of workers after medical cannabis became legalized. At both extremes, one patient to a large group, their outcomes. After the last presentation, we'll have a question and answer period, which time we'll invite questions and comments, for our speakers. If you haven't done so already, please remember to mute your cell phones. Trust me, it's very embarrassing when your phone starts blaring the laughter of the Despicable Me minions in the middle of a lecture. Done that. I won't read the biographies of our speakers. They can be found linked to the course agenda online. But as I introduce them, I do want to provide a few highlights which show their unique qualifications for the topics that they're presenting. First, our first speaker not only holds a Doctor of Medicine degree and an MBA in healthcare management, but previously earned degrees in chiropractic medicine and clinical nutrition. He has been a medical cannabis advocate, writing and lecturing on the subject, and has been a qualified physician in Florida's medical marijuana program since its onset. He also serves as medical director for minorities for medical marijuana. In addition to incorporating medical cannabis into his integrative medical practice, over the last 5 years he obtained training and certification in ketamine-assisted psychotherapy. Because cannabinoid medicine is such a young and evolving field, there's still a lot to learn about cannabinoids and how they interact with other medications to help achieve maximum symptom reduction with minimal side effects. Until we can accumulate the knowledge and experience to establish standards of care, how do we determine what treatment regimens are reasonable to try in clinical studies and for patients with symptoms which have not responded to traditional treatment modalities? One way is through patient case reports, and that's the value of case reports. So sharing with us from darkness to light how cannabinoids and ketamine treatment helped one patient overcome traumatic brain injury and mental health challenges is Dr. Joseph Rosado.
Good afternoon. Thank you. Okay. Okay, perfect. I have all my buttons figured out. I have multiple degrees and I can't figure out a freaking clicker. Anyway, so before we get started, everybody wants to know about my socks. So for Wendy, who's not here, I've got some psychedelic socks and tie-dye cannabis leaves on my bow tie. So there we go. I covered both bases. So how many physicians in the audience right now? All right, all are certifying, qualifying physicians except for Terrell, who can no longer certify medical cannabis patients. Everybody else certifies cannabis patients, yes? Yes, yes, yes? Okay, cool. So how many of you are using ketamine in your offices? Other than Terrell, of course. All right, so this is a really, really interesting case that has a really warm and special place in my heart, and as we progress, you'll understand why. So for those of you that don't know me or have never heard me speak, this is what I have done in medicine from the age of 16 until present. So everything that I've done medically from 16 to now. And in 25 short days, I'll be turning 63. I share a birthday with somebody else in this audience. I didn't say how old you were going to be. All right. This is what I've done in the medical cannabis space from 2014 to present. Before we had any laws in the books in the state of Florida, I was advocating with John Morgan and his brother all over the state of Florida, debating the sheriffs, debating politicians, debating everybody that would stand in front of me or next to me and put a microphone in front of us and we would go off. Fortunately, we did get it passed. This gentleman here is Professor Lumir Hanoush. He was the gentleman that named the first endocannabinoid that was discovered in 1992, anandamide, which comes from the Sanskrit word ananda, which means bliss. This picture was taken in Colombia, where he and I met back in 2018. So the introduction for today's presentation, as you can see, it's just an overview of combining different modalities. One size does not fit all. As physicians, we know that. That's why we use so many medications off-label, because not one size fits all. And so for that reason, combining different ways or different treatment modalities to get a better result with our patients is the key. So at the end of this talk, the key takeaway point that I want to make sure everyone gets is that this is going to demonstrate how integrating different modalities is going to be for the betterment of this patient, but not only this patient, other patients. Before I stood up on stage, we were discussing some other ketamine patients that we've been managing and how their questionnaires, the tools that we use to monitor their anxiety, their depression, and their PTSD, all those numbers are dropping, and how they're losing weight, and they've not been happy for months and years, and all of a sudden they're able to go away for the weekend and not be afraid of being in front of with other people. Go ahead and take a picture of this. These are the objectives for the talk, that because it is a CME lecture, you guys are going to have to grade me, and so at the end of the weekend, you can go back to your picture and say, did Dr. Rosado actually complete the objectives, so you can grade me appropriately. All right, and so we have the star patient. She is, or at the time she was, she's no longer 25, 25-year-old Latina trailblazer. She was a full-time electrical engineering student at UCF, a full-time bartender slash server at a high-end restaurant in Winter Park, Florida. And had a 3.8 GPA, so full-time student, full-time worker, and a real major, and vital signs 5'3", weighed 113 pounds, BMI of 20, and she's presented on September 20th, September 2020. Now, she came to me at 25. I met her when she was 15. She was a high school student with my daughters. So I've pretty much seen this little girl grow up. And she even calls me dad. So why did she come to see me in September 2020? Because she was stopped at a red light, waiting to cross over, had just gotten out of school, was heading to her job, and all she heard was a screeching sound of tires screeching, and she didn't know where it was coming from. All of a sudden, she felt the impact. Her head and body went forward. She went back, hit the back of her head with the headrest, lost consciousness, suffered a coup counter coup, and when EMS arrived, she was still unconscious. They transported her to the local emergency department, ran a battery of tests, no bleeding in her brain, musculoskeletal soft tissue injuries, discharged her. She went, found her primary care physician, et cetera, and so that's where the issue began. She reported that almost immediately upon regaining consciousness, she lost all impulse control. So she had nothing to control her impulses. She was very erratic, became very disoriented, and she reports that on January 20th of 2020, she felt and heard like a snapping sensation inside her skull, and from that point forward, she entered into a dissociative state where she has recollection of certain things, but not much from January of 2020 until she saw me in September of 2020. She deteriorated to the point where she failed out of school. She got kicked out of school because she was not attending her classes. She lost her job because she was not being responsible. Her 5-year monogamous same-sex relationship ended because she became very promiscuous and started engaging in utilizing street drugs. And her parents were at a loss and ended up Baker acting her. They held her against her will for 72 hours, and it was extended for an additional 72 hours. And then in September was when she decided to give me a call. So she came with the following diagnoses: PTSI versus PTSD, PTSI meaning post-traumatic stress injury versus post-traumatic stress disorder, general anxiety disorder with panic attacks, major depressive disorder with moderate recurrent, TBI, and post-concussion syndrome. In the emergency department, or I'm sorry, 7 months or 9 months after, they were working her up for her maximum medical improvement because she was not progressing and she had a TBI specialist. They ran a 3-dimensional neuroquant MRI of her brain. And the study, as you can see there, was not very favorable. And the last line is the one that freaked me out, was that she had the brain of a 70-plus-year-old because as a result of the accident, she had lost brain mass. She had lost volume within her brain, particularly in the area of the temporal lobe, and was given a poor prognosis. Now, granted, not everyone in this room is a Barry Gordon. We're not emergency room doctors, but for those of you that don't know, what is the CFAS? CFAS is the determination to see how urgent and serious a brain injury is. In her case, she was given this a CFAS score of 5, meaning that it wasn't an urgent situation and did not need immediate medical care. And so, how did I treat her? Obviously, always start with cannabis. And so I started her on my typical regimen, but I tweaked it a little bit in that I only gave her an indica dominant hybrid and indica. Why no sativa? Who can answer? Why no sativa? Yes, sir. There's already activity going on in the brain, but why no sativas? Exactly. She had no impulse control. Sativas stimulate. Sativas can make you more anxious and to a point of paranoia. How many of you have managed or treated or talked to somebody about medical cannabis and they'll say, oh no, I did that when I was in college and I got paranoid and I never want to do it again? More than likely because they use the sativa. Sativa stimulates. So in those cases, you want to stick with a hybrid or an indica-dominant hybrid for daytime use and a straight indica at night. Remember, indica in the couch.
So, Joe, and I guess it's a statement of wishing, but can you give us some of the terpenes in that sativa profile?
Can you pause and let me finish my lecture? Are you going to start? You going to start? You going to start? You going to start with me? Anyway, so indica dominant hybrid, indicas, and CBG. You'll understand why here shortly I went with CBG. 2 months later, I ran the what's called the NeuroQuant. I did the questionnaires that we do, and on her GAD-7, she scored a 21 of 21. On her PHQ-9, she scored a 26 of 27, and on her CAPS-5, she scored a 4 out of 5. Are any of you using these tools in your offices? Excellent. So what are they? So GAD-7 is General Anxiety Disorder 7. It's a 7-question questionnaire that tests and measures the anxiety of the individual or the severity of anxiety. So in her case, she was a 21 of 21. The PHQ-9 is what measures depression. A maximum score of 27. She had a 26 of 27. And then the CAPS, Dr. Newton will recall back in 2019, I lectured on PTSD and about utilizing the CAPS for our PTSD patients to measure before and after to determine how well the cannabis is helping with their PTSD symptomatology. What CAPS stands for is Clinician Administered PTSD Scale for DSM-5. And it's a 3-part series, and it's very extensive. It takes about 30 to 45 minutes to complete, but it gives you a wealth of knowledge. And so in her case, I had a baseline of where she was at. We were already starting with the cannabis, and so let's give the patient a break and let's get into the science. How do cannabinoids work or don't work on the brain? So in this study, where they compared cannabinoids in traumatic brain injury, looking at endogenous, plant-derived, and synthetic compounds, how they work on the brain with traumatic brain injury, and what we already know clinically, it does help reduce brain swelling, it does help restore cell damage, and it does prevent and support memory problems. Some studies have been done on animals as well as humans, and they have found positive results. Why does this matter? What's the treatment for TBI? There isn't any, exactly. And so this just gives us an idea of maybe something that we could use for individuals with traumatic brain injuries. CBD and brain injuries. We all know that CBD is an amazing anti-inflammatory. It's an amazing antioxidant. And when someone suffers a traumatic brain injury or any type of head injury, it causes a production of glutamate. Remember that neurotransmitter. And for those of you that have a positive ApoE3 or 3/4 like I do, which means that I have a very strong propensity to eventually develop Alzheimer's disease thanks to the great genetics I got from my mom and dad, go ahead and write down glutamate so you can remember it when we talk about it in the future. So when your head gets struck, you do produce some glutamate. CBD comes in and takes over and gobbles up that glutamate. CBD, we know, protects our brain cells. We know that it reduces inflammation, and we know that it improves the recovery of the brain. Why is this important? Again, a potential treatment for TBI. Now, is CBG stronger? How many of you have ever heard that CBG is 5 times stronger than CBD as an anti-inflammatory and an antioxidant? Okay, well, aside from it being 5 times stronger, it has up to 10 times greater affinity for the CB2 receptor, which is why in this young lady, I gave her CBG and not CBD. And I was focusing more on the THC side of things and not so much on the other. Yes, sir?
The CBD2 receptors that
Yeah, the CB2 receptor. Yeah, cannabinoid 2 versus CB1, cannabinoid 1 receptor. Yeah, it's one of the endocannabinoid receptors, correct, yes. Glad to see you joined us, sir. So CBG has 10 times greater affinity for the CB2 receptor. So for that reason, I chose to give her the CBG 200 milligrams twice a day rather than the CBD because, and you'll understand why in the next few slides. And so CBG has greater propensity for analgesia and also anti-inflammatory. Now, this slide is just for Barry. Happy? So, as you can see, there are two terpenes that have been linked with brain health, pinene and linalool. You can see that both help with anxiety and stress, both can help with memory and learning, and both can possibly treat conditions like Alzheimer's and depression. Now, let's look at them side by side. You will see that therapeutic effects are almost identical, with the exception of this over here, which is analgesia. Pinene has an analgesic effect because, as you can see over here, it works on the mu opioid receptor. So it has the capability to work and function as an opiate. And so it does help treat and manage pain. And not only that, they interact with brain chemicals. As you can see over here, all of the brain chemicals, but pay closer and special attention to BDNF on both sides, but also NMDA on the linalool side, okay? So remember these two terpenes, pinene and linalool, remember hybrid dominant indica, an indica dominant hybrid or an indica. Now, how can cannabis help, or can it even help brain injuries? Right now, there's only been one study that has been done with a cannabinoid to treat traumatic brain injury. A synthetic cannabinoid is the enantiomer of HU210, or Hebrew University 210, which are studies that were done by Professor Meshulam and are still being done now by Lumir Hanoush, where it showed that they used this dexanabinol. Dexanabinol is a synthetic cannabinoid that has been promoted and pushed as though it has neuroprotective properties and it can be used to treat seizures. For that reason, they decided to test it and see how effective it was for traumatic brain injury. And on this study, it demonstrated that it was not effective at all. However, because we know that other cannabinoids do have benefits, you can't throw out the baby with the bathwater and say, oh, no cannabinoids will help traumatic brain injuries. Understand that this one did not do anything, but there are others that can. So that's the take-home message from this slide. I'm sorry? They typically, the dosing is typically 0.5 to 1 milligram per kilogram. Yeah. So let's get into the ketamine pharmacology. So when I'm consulting a ketamine patient, this is what's going on in my brain. Sucks being me, right? Because that's what I'm thinking about, where the ketamine is working and how it's going to be affecting the person and what the results are going to be going on. So what does ketamine do? Ketamine is a blocker of the NMDA receptor. Okay, dexanabinol, which is that synthetic cannabinoid, also is an NMDA inhibitor. What other medications that we prescribe our patients is an NMDA inhibitor? Memantine. Well, memantine, Namenda for Alzheimer's, it's an NMDA inhibitor. So it blocks NMDA. By blocking NMDA, what does it stimulate or cause? The production of glutamate, which is why I did not want my patient to get CBD, because we saw in one of the previous slides that CBD lowers your glutamate levels, and we need glutamate. Why do we need glutamate? Because glutamate stimulates the production of BDNF. which is brain-derived neurotropic factor. This, BDNF, is what stimulates the formation of new brain cells. And by forming new brain cells, it allows for new synapses to occur. And once you have new brain cells and new synapses forming, now you're actually healing the brain. So when I was in paramedic school and was told that once you lost brain cells, you were screwed, now we see that that's not true at all. And it restores brain function because if you've got new brain cells and new connections, of course it's going to affect your brain function. In this next slide, it summarizes the previous slides where it shows that when someone suffers from chronic depression or is depressed, they shed brain cells and the brain begins to shrink and they lose dendrites. By incorporating the ketamine, causing the blockage of the NMDA receptor, causing the formation of glutamate, glutamate now stimulating the BDNF, forming new brain cells causing new synapses, boom. The key point, ketamine not only relieves the symptoms quickly, and you'll see how quickly here shortly, but it also promotes long-term brain healing because new brain cells, new synapses, new connections, and allows for brain growth. This little girl had the brain of a 70-year-old because she had lost brain mass. She had lost brain matter, but didn't have an open injury to her brain or to her skull. Now, ketamine for TBI. For years, people were concerned about utilizing ketamine for traumatic brain injury because of the fear of the increased intracranial pressure. They found that it does not cause any increase in the intracranial pressure, so it's completely safe to use on patients with TBI. For PTSD, you will also see, again, that it has a rapid onset and works very quickly, not only for PTSD, but also depression symptoms. What medication is out there that's promoted by the FDA at a price tag of $600 to $900 per treatment? What's it called? What'd you say? Esketamine, exactly. Esketamine has been approved by the FDA from 2019 forward for post-traumatic stress disorder, treatment-resistant depression, and suicidal ideations. And so this slide further supports and promotes the use of ketamine for PTSD and treatment-resistant depression. Comparing ketamine with midazolam, you will see that at 0.1 milligram per kilogram of ketamine versus midazolam, there was greater benefit using the tools, the HAM-D6 and the MADRS, which are tools, again, to measure anxiety, and showed that ketamine had a much better result managing and treating anxiety than midazolam. So, in summary, what should we know about ketamine? Number one, it helps people with depression that have been on treatment before and are still depressed. Treatment-resistant depression is defined as having been on at least 2 antidepressants, 2 mood stabilizers, and still being depressed. That is what treatment-resistant depression is defined as. People who are feeling suicidal, the 3 qualifying conditions or diagnoses for esketamine: treatment-resistant depression, PTSD, suicidal ideations. What are the possible side effects? Dizziness, sleepiness, blurred vision, feeling of being disconnected or dissociated, nausea, high blood pressure, and headache. Because of the nausea component, all of our patients are pre-medicated with either Zofran or Phenergan to avoid the possibility of developing any nausea or vomiting while they are in the middle of a session. Now, who should be careful? People with schizophrenia or psychosis, those who have addiction problems, teens because of the growing young brain, pregnant or breastfeeding people, older adults with memory issues. Dr. Rothman, what does this sound like? These things to be careful of. Where do we see these as medical cannabis doctors? In recommending medical cannabis, right? Isn't this what they always promote in Tallahassee? That someone that's got schizophrenia or has psychosis should not be on cannabis, or if you're a teenager, you shouldn't be on cannabis. That's the party line in Tallahassee. So pretty similar to what they're saying about cannabis, they're talking about ketamine. As always, more research is needed, even though the FDA has approved the medication, but more research is still needed. Why? I'll tell you why here shortly. And as far as ketamine and anxiety, although ketamine has been shown to help anxiety, you'll see here that it reduces anxiety, but it takes, within 2 weeks, they are suffering anxiety again. Why? Because it's not a one and done. It's a treatment program. You don't give them one and expect them to be better. You don't take one chemotherapy session and know that you're going to be fixed with your cancer. It doesn't work that way. So it's not a one and done. It is a process. And because it is a process, this study was really skewed because we know that the treatment per Yale, or the Yale protocol, is twice a week for 3 weeks. The S-ketamine protocol is twice a week for 4 weeks and once a week for 4 weeks. So we know that it's not a one time and you're good. So how do we prescribe cannabis? How do we prescribe ketamine? These are the 3 modes of administration that we utilize, which are the injectable, the intranasal, and the troches. Now, what is the difference between ketamine and S-ketamine? So let's go back to organic chemistry. Take your right hand and your left hand. Your left hand is the S-ketamine, and the right hand is the R-ketamine. They're enantiomers or mirror images, one of the other, depending on the chirality. One, depending when you shine the light, it's going to either rotate to the right or rotate to the left. Wax on, wax off, right? So right, left, mirror images. I never thought I would say that after I left organic chemistry class. Now, S-ketamine is 1/2 of the ketamine or racemic ketamine molecule. It's just the left side of it. Now, comparing the racemic with the S-ketamine, studies have shown that the racemic ketamine has greater benefits when dealing with mental and behavioral health issues as compared to the S-ketamine. So 80% is metabolized, and it converts to this other metabolites. But understand that it all is metabolized relatively quickly and easily in the liver, and then it's eliminated in the kidneys. Now, we mentioned earlier how quick it works. You can see here that the half-life is a little over 3 hours. So a typical session lasts anywhere between 1.5 hours to 2.5 hours in the office. Now, these are the routes of administration and the bioavailability. You will see that IV, obviously, 100% bioavailability, intramuscular, 93%, intranasal, 45%. This is what S-ketamine is administered in as an intranasal spray. Sublingual or oral mucosal, which are the troches, are 19 to 50%. Oral tablets or capsules, 17 to 27%, and intrarectal, 30%. Now, because this is a CME function, I cannot tell you why I use intramuscular instead of intravenous. But at the reception, I can tell you why. Heard? Noted. All right. Now, for those of you that are visual, a picture is worth 1,000 words. So 100% bioavailability for intravenous, 93% for intramuscular, 8 to 45% intranasal, 17 to 19% oral, and 11 to 25% intrarectal. You'll never forget that one. Now, acute antidepressant effects comparing intravenous with intramuscular. We all know as physicians that when you prescribe an SSRI or an SNRI or a mood stabilizer, it's going to take how long before the person feels the effect? 2 to 4 hours if 2 to 4 weeks if you're lucky. With ketamine, within minutes to hours after their initial session, their PHQ-9 numbers drop and stay dropped for as long as 7 days, with a uprise or a peaking going up at day 3 to day 4, which is why twice a week for 3 weeks is the standard of care because you want to give them their treatments within a 72-hour to 2 to 3 day or 3 to 4 day increment to make sure that their numbers don't come down. And because you're dealing with long-term, long-standing chronic depression and PTSD, you want to make sure that they don't revert backwards, that they're constantly moving in an upward direction. And in the comparison, they compared 0.25 milligram per kilogram of IM versus 0.5 milligram per kilogram IV, and there was minimal difference between the two. So it's pretty comparable, and you're really only giving up a 7 to 8% bioavailability. What do we dose, or how do I dose my patients? My standard dose is 0.5 milligram per kilogram. However, the range is 0.1 to 0.75 or to 1. So 0.1 to 1. Prior to getting up here, I was talking to Dr. Newton, who is an anesthesiologist and has a lot of experience using ketamine for anesthesia. What's the standard dose for anesthesia? Dr. Newton? So 10 times as much as a loading dose. We're giving them a 0.5 per milligram per kilogram bolus intramuscularly. There's no way that they're going to go into an anesthetic state, okay? And it's being used for chronic pain. So people with chronic regional pain syndrome, that dose is anywhere between 1 milligram to 5 milligrams per kilo of body weight. So again, we're nowhere near that threshold, so the possibility or probability of them having an adverse reaction is minimal to none. Also, these receptors, the NMDA receptors, are not found in the brainstem. So there's no possibility of losing, not breathing or dying, or what mainstream media has been promoting about Matthew Perry. Because when he died, everything was, oh, he was on ketamine. He was getting ketamine from the black market. But when they did the autopsy, they discovered in the toxicology report, he not only had ketamine on board, we know what the half-life of ketamine is. We already said it. It's 3 hours. He had benzodiazepines on board. He had buprenorphine on board. What's the brown box warning for combining buprenorphine and a benzodiazepine, Dr. Newton? But that combination can lead to decreased respiratory rate. He also drank some alcohol. There was alcohol in his system, and he took a hot bath. He didn't learn from Whitney or her daughter, because all of that on board and then going into a hot tub and taking a bath, that's what killed him. It wasn't the ketamine.
One advantage of that combination is ketamine and cannabis neither suppresses the respiratory drive, so you can safely give this in the office, even a patient that's starting cannabis and starting ketamine.
Exactly, because the receptors are not found in the brainstem, contrary to the opiate receptors, which buprenorphine, being a synthetic opiate, works on that receptor. So, back to the patient. How did I start treating her with the ketamine? We started with the troches. Twice a week for 3 weeks. We started with a 200 milligram troche. One troche is scored into 4 pieces, and so it's 50 milligrams per corner, so a total of 200 milligrams per single troche. So we started at 200, and every treatment we increased by 50 milligrams to a total of 450 milligrams. Then we went the IM route. Now remember, I told you she weighed 50 pounds, or I'm sorry, 50 kilos. So her dose would have been a 25 milligram, but because she had already started with the troches, I started her 5 milligrams higher, and every treatment I upped the dose by 5 milligrams because of the possibility of developing a level of tolerance. So I upped her dose every time by 5 milligrams. What you see there is the concentration. Ketamine comes in either 50 milligram per milliliter or 100 milligram per milliliter. I was using the 50 milligram per milliliter for her. So that was until March. These were her numbers in March. Her GAD-7 was now a 9, her PHQ-9 was a 13, and her CAPS is now a 2. comparing one with the other, you will see that there was a 50% decrease in the CAPS score, there was a 50% decrease in the depression scale, and there was almost two-thirds, about 50%, or a little more than 50% difference in the GAD-7 in 6 months, because I started seeing her in September, and this was in March. But because I'm anal, because by trade I am an internal medicine doctor, and you know we are the most anal that exists, what did I decide to do? Repeat the MRI. No guts, no glory. Normal MRI after 6 months of treatment with cannabis and ketamine. And if you're questioning it, I brought the reports with me. So I have the reports on site. I was working my butt off to get her to be here today. So for the Q&A, you can ask her, but she's working. On December, and now is when you're going to see the Joe that you're used to seeing, the crybaby. But 9 months later, on New Year's Eve of 2021, she invited me to go to her restaurant and have dinner on her. And so I get to the restaurant, and the hostess is waiting for me at the door. And so I show up, and I'm like, I'm Joe Rosado. I was invited by NK for dinner. And she's like, oh, you're her doctor. And I'm like, yeah. And her manager comes from around the corner and says, I don't know what the hell you did, but she's amazing. It's like, we got our girl back. I'm like, okay, well, thank you. I'm like, I need to use the restroom really bad. Can you show me where the restroom's at? She's like, sure, it's in the back. As I'm going to the restroom, I go past the bar. As I'm getting close to the bar, I did say it was New Year's Eve. So what happens New Year's Eve at a bar? You're like 4 or 5 people deep. And I look to see who's behind the bar, and it's her. And here she is, mixing drinks, taking orders, not writing anything down. That's her superpower. She takes orders as a server, and she doesn't write anything down. So she knew how bad she was when she couldn't do her job the way she was accustomed to doing it. So I'm watching her, and she doesn't know I'm even there, and she's going about her business, whatever. I go to the restroom, I come back, and I'm standing in an area where I'm hidden, but I'm still watching her, and she's flipping the bottles, giving everybody a show, and rattling off orders and everything else. All of a sudden, she turns around, because, when you stare at somebody long enough, you feel that level of uneasiness. It's like, who's watching me, who's staring at me? And she turns around, she screams, Dad! She jumps over the bar, jumps into my arms, wraps her legs around me, gives me a big kiss and a hug, and says, let's go eat. This is why we do this shit. So, from villain to victor, ketamine in acute neurological injuries. Sorry for the smallness of it, but you will see that the key terms and the key points that I want to make sure that everyone gets is the fact that it is an NMDA receptor antagonist. It allows for the formation of glutamate, which stimulates the formation of BDNF, which allows for the formation of new cells in the brain, new connections, and a new life. Thank you.